A very good morning to everyone present here. So, today we are going to have a small discussion about the classification of bone grafts. The reason I chose this topic is I've seen a lot of clinicians having difficulty in understanding uh, what what bone graft is from what source and how it is it can be useful in clinical scenarios. So I just try to put up a very simple single slide where we have given the various types of bone grafts available for hot tissue regeneration. So I just give a very brief and easy understanding. I'll just take you take you through this in a very easy way so that you will understand that what bone grafts are from which source and where it can be effectively used. So you know that bone grafts are very popular choices for heart tissue regeneration, and they have been they are time tested. It's not that they are very new and they are in the experimental stage. They are very well time tested, and the gold standard in bone grafting is the use of autogenous grafts. Okay, and we have so many other sources like allografts, xenografts from animal sources from another person of the same species. We have some synthetic bone grafts also available. Okay, so with this short introduction, I'll go into the actual classification of bone grafts. So bone grafts can be broadly classified based on the source as autogenous bone grafts, allogenic bone grafts, xenogenic bone grafts, and your synthetic bone grafts. So what are what is this autogenous bone graft? So autogenous bone grafts are those type of bone grafts where the source of the bone graft is our own self. For example, if I'm doing a surgery on a patient and I'm going to use the bone graft harvested from the same patient, that type of bone graft you want to call it as autogenous bone grafts. Of course, they are safe because taken from the same patient. They don't have that allogenic potential, that immunogenic reactions or any other transmission of diseases. All these are the the pluses, and being an autogenous graft with viable osteoblasts, bone forming cells, they form the best quality bone. So in the category of classification, the first category will be your autogenous grafts, which means the grafts taken from the same individuals. Okay. So coming to the sub-classification of these autogenous grafts, there are two sources of these autogenous grafts. The one source is going to be your intraoral source and the extraoral source. Being a dentist, we are more familiar with harvesting grafts intraorally, like we can harvest the grafts from various parts of the oral cavity, like the chin. We can use some harvest some bone from some extra sources, kind of bone deformities. Tori, we can harvest bone from the ramus and from the tuberosity. Each location has its own pluses and minuses. For example, the chin, the ramus, they have dense cortical, so we can use bone grafts harvested from here, and we can use them in the form of a block graft, which means you take a block of bone and then you can fix them onto some defect site where you are going to regenerate. For example, if you have an implant site which does not have sufficient bone dimensions like height and width, you can use this autogenous bone blocks and you can regenerate. The most importantly, you can regenerate vertical bone height, which is very, very challenging nowadays. Lateral bone augmentation or the horizontal bone augmentation is more predictable, whereas vertical bone augmentation is more challenging. Not saying that it's impossible, it's more challenging. So Intraorally, we can harvest graft from these sites. Other intraoral sites like your exostosis, the ramus, the tuberosity, and the temptori, they have the mix of both cortical and cancerous bone. So you can harvest both uh, uh, block kind of grafts or some particular grafts from those areas. And we use some special chisels, bone rangers, bone files. We have some very advanced instruments like your scrapers. It's called as bone scrapers, where you can scrape the cortical layer of the bone and you can harvest autogenous bone. The only limitations of this intraoral sites will be your limited availability of. For example, if you want large volume of bone graft for your regenerative procedures, probably depending only on intraoral sites may not give you, uh, sufficient bone volume, because we cannot harvest from multiple sites, and there's going to be a lot of morbidity, too much of pain and discomfort to the patient during the healing phase. That's why we look upon to the other option, which is the extraoral sites. Then the common extraoral sites for autogenous bone grafting are your bone grafts taken from the iliac crest, tibia, fibula, and the ribs. And we can even take bone from your scalp. Even your scalp, with the skeletal, the bone below your scalp is going to have a very dense cortical plate, and there are no case reports of successful bone harvesting and usage from bone from your skull, that is below your scalp. So the reason why I told you the reason why we use these extraoral sites, it's mainly for your better bone volume of harvesting. Okay, so when you're looking at reconstructing the mandible post mandibular resection, hemimandibulectomy, and all those procedures, you need huge volumes of bone. And for reconstruction purposes, mostly extraoral autogenous bone will be the best source. Okay. Now, imagine the patient doesn't want a surgical site in his mouth or any other part of the body. He's very apprehensive patient, and he says, "Doctor, don't do any additional surgeries. Look for other options." What are the other options? The other options is going to be bone grafts, by name as allogenic bones. Allogenic bones are bone grafts which are sourced from different individual but same species, which means dead donors. So diseased individuals, not diseased, which means dead individuals, their bones are harvested, it is processed, or it undergoes rigorous processing where the any possible infections are eliminated. The bone material is processed in such a way that they lose the immunogenic potential, that uh, you know, allergic and immunogenic reactions will not be happening because of that process called lyophilization. It removes all the immunogenic potential of those bone grafts. The biggest advantage with this allogenic bone is this is almost similar to your native. It's from the same species, from but different individual. So it is almost it's almost same bone. The only problem is infection transmission, if at all. I don't think there is any possibility of such things happening in the present scenario, because we have come a long way in terms of manufacturing and processing of all these allogenic. So we have many companies like this Zimmer and Rocky Mountain. They are very popular allogenic bone graft materials, and they have maintained excellent standards in terms of procurement, harvesting, and processing, and commercial availability. So, in this allogenic bone, which is bone obtained from same species from another individual, we have frozen bone, we have freeze-dried bone allograft, we have demineralized freeze-dried bone allografts, and we have deproteinized bone allografts. Of these four types of bone grafts, most popular ones are FDBA and DFDBA. FDBA stands for freeze-dried bone allografts, and DFDBA stands for demineralized freeze-dried bone allografts. So these two bone grafts are the most popular choices when you want to do use these allogenic allografts for dental regeneration. The big difference between your FDBA and DFDBA will be because the DFDBA is a demineralized bone, the resorption time is lesser, is more, which means it's going to resorb faster when compared to FDBA. So if you're going to use any sinus grafting procedures, the best choice will be use of FDBA and not DFDBA because they stay for a long time. Sinus grafting procedures, sinus is a relatively less vascular zone. So we need a material which can stay for a substantial period of time, which syncs with or matches with the remodeling phase or osteogenic potential of that surgical site. Okay, so better to use a FDBA for sinus augmentation procedures. For all other implant-related work, ridge augmentation, socket augmentation, socket preservation, the use of DFDBA will be a better choice. DFDBA has got the advantage that it is demineralized and it has got more bone morphogenic proteins. I told you that autogenous bone has got the biggest advantage that it's got live viable osteoblasts. That's why it's so osteogenic. And the mechanism of bone formation using autogenous graft is called as osteogenesis. Whereas the mechanism of bone formation using allogenic bone graft is called as osteoinduction. This osteoinductive potential of these allogenic bone grafts is because of the presence of a specific and very important bone regenerative growth signaling molecules like the bone morphogenic protein. There are so many types of BMPs available, and these BMPs are preserved. They are just proteins. They are preserved in the processing and lyophilization and the manufacturing process, and this helps in superior bone formation when compared to xenogenic graft or synthetic grafts. So technically, these allogenic bone grafts comes under as you can categorize them as number 2 in terms of the quality of bone formation, the ease of bone formation. The first will be your autogenous graft, second will be your allogenic bone grafts. Now, having seen human bone, either from the same individual or different individual, for example, again, if the patient requests you, doctor, I cannot accept some other individual's body parts. It's like a donor, right? He's a donor now. He's a recipient now. So if anyone uses a bone graft from different individual, it's like a organ donation. They're very skeptical about infection transmission, or if they are mentally not comfortable, probably we cannot use allogenic bone. So what is the next option? The next option is that we can offer the patient something called as xenogenic bone. Xenogenic bone or xenografts are bone grafts which are obtained from animal sources. That is different species, non-human bone. So xenogenic bone grafts are very popular among dental regeneration because they are free from all human infections like HIV and hepatitis B infections, and they are available in huge quantities. And because of the superior technology available now, all these bone formation process has been more refined in this with the use of these xenogenic graft materials. And the most common source for these xenogenic bone grafts are the bovine, porcine, and coral derivatives, coral calcium carbonates. Bovines are your cow and other sources. Porcine is pig origin, and coral derivatives are corals are uh, sea products, sea animals, and you can use the calcium carbonate, and these are come from the category of xenogenic bone. When we cannot use a autogenous bone or a allogenic bone grafts, this becomes the third choice for clinicians for any kind of regenerative procedure. It's going to be ridge augmentation, socket preservation, sinus grafting, or peri-implant defect management. These xenogenic bone grafts have become very, very viable choices because they are relatively cheap, available in huge quantities. We have we have so many commercial players offering these bone grafts, and as I told you, with better technology nowadays, all these bovine related diseases like bovine encephalopathy, hand, foot, and mouth disease, all these kind of transmissions have been completely neutralized, and there's almost no reports of such disease transmission using these xenogenic bone grafts. The mechanism of bone formation using the xenogenic bone graft is called as osteoconduction. Of course, even a allogenic bone can form bone by osteoconduction, but predominantly it is osteoinduction, then osteoconduction. If you see the mechanism of bone formation using xenogenic bone, the predominant mechanism of bone formation will be your osteoconduction. Okay, osteoconduction, where these bone graft materials, they don't have any active molecules. Okay, unlike your BMPs present in allografts or your viable osteoblast cells present in your autogenous bone. These xenogenic bone grafts, they just act like a scaffold, which means in a defect, you'll have one three-dimensional scaffold, and over this three-dimensional scaffold, you have a stable blood clot. Over and around this three-dimensional scaffold, you have a solid blood clot formation. And this blood clot, over a period of time, starts getting organized, and formation of then the bone cells start migrating from the neighboring bone surfaces, osteogenic surfaces, and they lay the woven bone, and the whole bone formation process kicks in. So xenogenic bone grafts, as I told you, significant advantages. They have a very similar bone structure to human bone. They are available in huge quantities. They are relatively inexpensive when compared to other kind of bone grafts. Of course, mild drawbacks are very, very rare complications are this bovine encephalopathy and this animal-borne diseases, which are completely almost there are no incidences anymore. So xenogenic bone grafts are good choices for use in socket preservation, ridge augmentation, sinus grafting. So this particular bone grafts can be used in many scenarios. Unlike autogenous bone and allogenic bone, which can be used in only specific scenarios, these xenogenic bones can be used in multiple scenarios. That makes them as popular choices for bone grafting procedures. Autogenous bone, though they have superior bone formation, they are very quick in terms of resorption, which means if you place an autogenous bone into a defect site, it resorbs very fast. Good in one way. A grafting material should resorb, but it should resorb in an optimal duration. It cannot resorb very fast because bone formation is a slow process. See, any grafting material should stay. I told you we should sync with the mechanisms of bone formation there. So if you use an autogenous bone for a sinus grafting procedure, you're not going to get any significant bone formation. So there you should use a combination bone graft. It's called composite bone grafting. So you can use the advantages of viable cells in your autogenous bone graft. You can add them to your xenogenic bone grafts and get the best of both. Xenogenic bone grafts resorbs very slow. Autogenous bone grafts resorbs very fast. Autogenous bone grafts have viable bone cells. Xenogenic bone grafts have beautiful three-dimensional scaffold, which maintains a space in the surgical site. So a mix of this both in the right proportion, usually 1:1 ratio, are very good choices in sinus augmentation procedures, ridge augmentation procedures, and so on. Of course, you can even have patients complaining that, no, I don't want animal source. For example, there can be religious concerns if you're going to offer a patient a bovine source material or a porcine source material. There, the next choice of bone grafting will be your alloplastic materials or allografts or your alloplast. Okay, these materials are synthetic in origin. Okay, alloplast or your synthetic bone grafts, they are from non they are not biological bones. They are not from animal source, they are not from human source. They are engineered bone graft particles or bone void fillers. Okay. And the popular choices of bone graft in your synthetic bone grafts or your alloplastic materials are your hydroxyapatite materials, your calcium phosphate cements, beta TCP, popularly called as beta TCPs. It's your beta tricalcium phosphate material. You have your biphasic alloplastic material, which means when you combine a hydroxyapatite and a beta TCP, you call them as a biphasic material. They are normally available in the ratio of 30 is to 70 and 40 is to 60. Among these synthetic graft materials, the popular or the most robust type of bone formation is happening with your bioactive glass, and then you have your synthetic polymers. Synthetic polymers, methyl methacrylate polymers are also becoming are evolving rapidly, and these bone graft materials will have a dominant role in the near future. So synthetic bone grafts, again, we have to accept the fact that they are from non-biological sources, which means there is no disease transmission occurring. But what is the problem? The problem is their extremely bio-inert nature, which means they don't have any specific activities in the bone graft, which means they act like just fillers. Okay, they does not induce any bone formation. They does not stimulate any osteoprogenitor cells in the nearby zone. So they are just inert scaffolds. Okay, of this hydroxyapatite are not great choices because they does not resolve at all. There are scientific evidences that these graft materials they stay up to 10 to 12 years without any resorption, which is not something which we can use it for our implant practice. So the calcium phosphate and TCPs are very fast resorbing materials. They are good in terms of bone formation, but they are, again, the problem is that they resorb very fast, which means they cannot stay for a long time, sync with the surgical site for a bone augmentation procedures, bone regenerative procedures. So again, we can look for the option where these fast resorbing material can be mixed with a slow resorbing material. For example, you can use a TCP with a TCP with a hydroxyapatite. That's why that biphasic alloplastic material came into existence. Okay. So we can have a mix of both. We can have the best of both to get optimal or a superior bone formation, at the end of your follow-up time. So bioactive glasses, I want to give a short note about this bioactive glasses. And before that, the mechanism of bone formation for most of these alloplastic materials is going to be again by osteoconduction, which means they're going to be a bio-inert scaffolds, both xenogenic bone graft and your alloplastic materials, bone graft. The mechanism of bone formation is osteoconduction. Differentiating them from this alloplastic material is your bioactive glasses, where they form bone by the mechanism of osteopromotion. Osteopromotion can be defined as a process where there is a stimulation of the regional bone cells by changing the pH of the surgical site. These bioactive glasses have all these silica molecules. They change the regional pH, make them more acidic, and they stimulate the regional cells to form new bone. That's the explanation for osteopromotion, or they also use a word osteostimulation and osteopromotion. And synthetic polymers, they're emerging, of late, and we'll see more details about them in the future. So this is a brief gist about each type of bone graft, how are they classified, and where can be they used more effectively. Okay, and we use all these bone graft materials for multiple purposes like socket preservation, peri-implant bone defect, periodontal bone defect, sinus augmentation for implant placement at a later date, ridge augmentation, periapical surgeries. You have a huge periapical cyst and there's a huge defect there. You can, after your debridement of your periapical lesion, you can graft these material, fill those material defects, and you can get good bone formation. Post mandibulectomy or maxillectomy, these can be used for reconstructive purposes. So I hope this video gives you a decent insight about the types of bone grafts available. Of course, this is not for the seasoned clinicians, especially periodontists and people who do use bone grafts, left, right, center. This is more for beginners, undergraduates, and first year to postgraduates who want to understand what is how are bone grafts classified. Okay, hope this video will be very useful for you. Meet you with some other video at a later date. Thank you. Good day to all.